Hello, this is Dr. Mike, and for our last lecture in the series, we want to talk about psychological disorders. And in thinking about that, I wanted to just caution you, number one, to be careful how you read this chapter and think about it. We tend to all want to be rocking chair psychologists and label people. That is the medical model of the day that we live in. You realize you get a label stuck on you; it's very difficult to get it off. Be very careful about labeling people psychologically because there are different levels of psychological disorder. Some of them you function with, and others you increasingly can't function with. For instance, as a Southerner, we use the word crazy all the time. You're crazy. That is not a medical term. That is not a psychological disorder. There is no such disease as being crazy. There are neuroses, psychoses, and then there are disorders that are important. This is one of the most interesting courses that I took in my undergraduate studies in psychology was that of psychological disorders, and I think you'll find this chapter to be equally as interesting. We hope to define what those disorders are and their prevalence, and to talk about symptoms and possible origins of where they come from and possible treatments, and those are all important. As we look at these symptoms, don't try to diagnose yourself either. If you have concerns about your mental state or somebody else's, always go to a professional and get treatment for that. So, truth or fiction, a man shot the President of the United States in front of millions of TV witnesses and was found not guilty by a court of law. That was true. And that would be considered a psychological disorder. Psychological disorders are characterized by rare or unusual behavior, faulty perceptions or interpretations of reality. Some people have hallucinations or ideas of persecution, and there are all different levels of those things. Some people have them and can function, some have them and have to be institutionalized. But they indicate severe personal distress. They can be self-defeating, they can be dangerous, they can be socially unacceptable behavior. So first thing I want to talk about is this anxiety is abnormal. That is false. That is a fiction. Everybody has certain levels of anxiety. For some people, though, anxiety does different things to them. Perspectives of psychological disorders have gone through a gamut of understandings. One would be the demonological model, that it's because of demons or a person's demon possessed. And that would have held sway in human history up until the late 1800s with the rise of Sigmund Freud. Then there was a medical model, that it was some kind of a physical, biological illness. And then we come today to the idea of the contemporary idea of psychological models and what causes a person to have these disorders. The DSM-5, which some of you will run into if you work in the medical field, is a diagnostic and statistical manual that defines these different psychological disorders. It gets updated and compiled by the American Psychological Association. About half of us will experience a psychological disorder at some point in our lives. Most often starts in childhood or adolescence, and probably a little more than 25% will experience a psychological disorder in any given year. That doesn't mean that you're crazy, if you want to use that word again. It means that you probably just need some help. So look at this past year in lifetime prevalences of psychological disorder. Prevalence during the last year of anxiety disorders, 18%, mood disorders, 9.5%, bipolar disorders, 2.8%, substance use disorders, 3.8%, any disorders, 26.20%. Let me say that there are things that heighten the presence of psychological disorders. One thing that I have discovered in living in Colorado, where marijuana is legal, is that it has brought out more psychological disorders. It has lowered the gate. It has lowered that repression of holding things under control, and it has loosened people's inhibitions. And so you see a lot more mental illness in a drug-related world or an alcohol-related world. All those things conflict, and especially if they're on medication for their disorders, those things don't mix well. So something to think about. The insanity plea, this is John Hinckley, who tried to assassinate President Reagan in the 1980s. The McNaughton rule states that the defendant did not understand what he or she was doing at the time or did not realize it was wrong. This defense is used in about 1% of all court cases. So psychological features of a disorder that you need to think about: worrying, fear of worst happening, fear of losing control, nervousness, inability to relax. Physical features: arousal of the sympathetic branch of the autonomic nervous system, trembling, sweating, racing heart, elevated blood pressure, flushed face, faintness. All these things alone and by themselves are not major issues, but when they come together with a psychological disorder, can indicate a lot of things. One of the anxiety disorders would be special phobias, irrational fears. We all have fears, but when they become irrational to specific objects or situations, like claustrophobia, arachnophobia, agoraphobia. Arachnophobia, fear of spiders. Some people have they can't function. I've known people that literally went berserk over spotting a tiny little spider. Claustrophobia, the fear of enclosed places. Agoraphobia, the fear of open spaces. People at different levels of anxiety over even walking into an open room where people are, or walking across an open field, or being closed in. Social anxiety disorder, social phobias, are persistent fear of scrutiny by others. What are other people's thinking? Are they looking at me? Example: fear of public speaking, stage fright, speech anxiety, dating fears. All of these are examples of anxiety disorders. Panic disorder, the abrupt attack of acute anxiety not triggered by a specific object or situation. Person that goes into a panic disorder: shortness of breath, heavy sweating, tremors, pounding of the heart, suffocation, choking sensations, nausea, numbness, tingling, flushing or chills, fear of losing control. All these indicate a panic disorder. There are things called generalized anxiety disorders. Persistent can't be attributed to any kind of object, but they have motor tension, autonomic over-arousal, excessive vigilance, that kind of thing. And there are all different levels of these as far as the ability to work them out. So from a psychological perspective, phobias are conditioned fears. They're fears that we've learned to be afraid of. Anxiety is attributed to observational learning, things that we see, and cognitive bases can exist toward different kinds of threats. The biological view: anxiety can be caused due to genetic factors, reflects natural selection, things that we've learned through evolution. Psychosocial view: the cause of anxiety is the interaction of biological, social, and psychological and biological factors. Obsessions: obsessive compulsive disorder, OCD, recurrent anxiety provoking thoughts or images that seem irrational, beyond control. We have compulsions, thoughts or behaviors that tend to reduce the anxiety connected with obsessions, or irresistible urges to engage in specific acts. There are people that have to touch things. They have to touch a table or whatever. Those are compulsions. They can be at all different levels, from just, minor to major. Hoarding disorder. This is one you see a great deal on the news now. Overpowering need to accumulate certain possessions. They have difficulty with discarding them. People that hoard, I've seen people that hoarded cardboard or hoarded clothes or all these other things. And then there are other related disorders, the body dysmorphic disorder, preoccupation with exaggerated or imagined physical effects. People have this mental image that they are fat when indeed they're extremely skinny. That can be very, very trauma producing. Post-traumatic stress is one we see quite a bit today among our military, returning military. It's caused by traumatic events, may occur months or years after the event, take the form of intrusive memories, recurring dreams, flashbacks. My roommate is in the military and spent a term in Afghanistan. He was blown up 5 times, and even the ringing of a bell can cause a flashback and take him back to the scene, and he'll be sweating and heart will be racing and all those things. And that's been now almost 10 years since it happened, but it still occurs. Acute stress disorder occurs within a month of the event, lasts from 2 to 4 weeks. This chart shows sleep problems among Americans before and after September 11, the blowing up of the World Trade Center. Look at the difficulty of falling to sleep increased. Frequent awakenings have greatly increased. Waking early, waking unrefreshed have increased. So stress and all these things actually cause this to be much worse. The splitting of dissociative disorders is the splitting of mental processes of one's own identity, thoughts, emotions, identity, memory, consciousness, knowledge. All these things can happen with different kinds of these disorders. Dissociative, DID, 2 or more identities, where a person has a split personality. Each of those personalities have different traits occupying the same person. This used to be called multiple personality disorder, and that name has recently changed. So the dissociative amnesia, sudden inability to recall things that are important. Depersonalization, derealization. People detach from oneself, feel like the world is unreal or they're outside themselves. These are all becoming more and more common today. So where do these dissociative disorders come from? The learning theorists and cognitive psychologists believe that dissociative disorders may help people keep disturbing memories or ideas out of their mind. It's a way to have a safe place to go to withdraw back from, to get away from those thoughts. Most cases of dissociative disorders are culturally bound. They're limited to the United States and Canada. That's interesting. People complain of physical problems with sleep, the summative form, with no evidence of physical abnormality. They feel like they're paralyzed or they're in pain or they're persistent belief of serious disease. There's something wrong with me. Some people have persistent surgeries. There are people that invent things to get to have things removed from their bodies, which is really interesting. Illness, anxiety disorder, the insistence of serious physical illness despite no medical evidence of the illness, and may seek opinions from multiple doctors. Conversion disorders, major change in or the loss of physical function, no medical findings to explain the loss, not intentionally produced, but they can have a psychosomatic paralysis, even a psychosomatic blindness where people can't see, but it's all in their mental state. The biopsychosocial perspective, people focus intently on an imaginary physical problem and exclude conflicting information. Tendencies toward perfectionism and rumination are largely inherited. So a lot of these things can get passed down from generation to generation, which is interesting. Mood disorders are characterized by severe or prolonged disturbance in expressed emotions, can impair a person's ability to function. Many of you have heard about bipolar disorder. People have extreme mood swings. They can go from elated or manic phase to depressive behaviors, from argumentative and making poor judgments and show pressured speech and rapid flight of ideas to being lethargic, having insomnia and agitation. Feeling elated is not always a good thing, and that is true. Symptoms of major depressive disorder, and this is one that large numbers of people seem to be suffering from these days, but poor appetite, serious weight loss, agitation, psychomotor retardation. Some engage in psychotic behavior, which involves delusions of being unworthy or guilt for imagined wrongdoings or notion that one is rotting from disease. All those are part of this depressive disorder. The origin of mood disorders, learning theorists believe that people lack reinforcement and have an external locus of control. Links between depression and learned helplessness. Cognitive behaviors contribute to depression, like perfectionism, never being able to be as perfect as you think you ought to be, unrealistic expectations. All these things are vitally important. A biological view says that depression is associated with neuroticism, underutilization of neurotransmitter serotonin, not enough serotonin. And so they treat this in different ways. Depression can be a reaction to extreme loss, extreme stress, all those things. Women are twice as likely to be diagnosed with depression as men. A lot of that is encountered during childbearing years. Sometimes it's due to having children too close together and your body not being able to rebuild itself and rejuvenate before you have another child. Low levels of estrogen, rumination about stress and negative events. A lot of the demands placed upon women are that way. Suicide is the third leading cause of death among 15 to 24-year-olds in this country. Isn't that sad? So factors in suicide: feeling of depression, hopelessness, adolescent psychological problems, stress life events, familial experiences with psychological disorders, or suicide. And you need to be very much aware of these factors, these risk factors, because they can be quite present in our young people today. I had a former student from years ago who called me one morning, and he'd come home to find his 14-year-old had hanged himself in his closet. Had no indication whatsoever that the kid was thinking about suicide. But that is heartbreaking. It's something you never get over. There's a lot of other social cultures involved, more common among college students than people of the same age who don't attend college. Older people are more likely to commit suicide. Suicide rates among older, unmarried, or divorced people is double that of older married adults. And so all these things are interesting. 1 in 6 Native Americans have attempted suicide. African Americans are the least likely to attempt suicide. And about 1 in 8 Latin Americans have attempted suicide. 3 times as many women attempt suicide. 5 times as many males succeed in suicide. So not only do they succeed, but try it, but they are much more successful. Some of the myths you need to be aware of: individuals who fail at suicide are only seeking attention. That's not true. Discussion of suicide prompts suicide attempts. Not true. People who would take their own lives are insane. That is not true. Truth or fiction: people who threaten suicide are only seeking attention. That is false. So as you think about all these factors, be sure to register those things that should be warnings in your children, those around you, even in yourself, that you need to get attention and help. Thanks.